I just want to correct the introduction. That was, I think she has taken from my CV. I work with the Yashoda hospitals at Hyderabad. And on the first instance, I thank Meril for giving me a talk on something which may not be directly related with their product, but I thought it is recently we have developed a little bit of interest in this technology which has been developed by a Japanese surgeon, and he has found good results in this over good even 10-year survival rates. And so just it is also a type where we can use the bovine pericardium, which the Meril people are developing now, and it would be shortly released into the market. So just going to my talk, just I would like to give an introduction to my team who are constantly working behind us. We have a very skeletal team, but they are the ones who are our backbones and taking care of our patients in the ICU and also in the OPD and the post-op care and all. So, being today's topic of surgical valve replacement, as yesterday a lot of speakers have been telling about mechanical valve and pericardial bioprosthetic valve, I would just like to just throw a small a few slides on each one of them. So the mechanical bileaflet valve has become a standard of whatever company we use, and we have been using frequently this the Meril valve for the last 2 years, and I don't have the follow-up, but at least my cardiologist is not complaining. That is the only follow-up. If he has some issues like there is thrombosis or anything, naturally he would have sent the patient to us. So all these good features of the Meril bileaflet valve have been discussed. So I will just run through these slides. The thing which we feel is of good advantage is there is no cavity pivot which has been present in other bileaflet valves. We had a few issues with the Secunderabad valve quite a few years back, where they used to get stuck in the immediate post-op period, and due to my personal experience, I stopped using the Secunderabad valve, and we were using the other valves. So luckily, we are not having major issues with the mechanical bileaflet valve of Meril. And so these all have been discussed yesterday, so I just want to go through them quickly. Being a pericardial bioprosthetic valve also is, the design is very good, and we are seeing quite less gradients. We have to wait for the long term to see how they perform. So this is the numbers which we have done over the last 2 years, roughly around 32 mechanical valve and 23 bioprosthetic valves, and our age has been like around average of 45 in the mechanical valve and around 57 for the bioprosthetic, and ICU stay and has been all reasonably good, and we didn't have any immediate post-op mortality or thromboembolism. Actually, we don't have any reported, so we have not been following it that. We shall be doing them once we have a little bit of data more available. So now coming to the topic of today, just wanted to throw this Aortic Neocuspidisation has been developed by one of the surgeon, a Japanese surgeon called Dr. Ozaki. So if you want to see that, he in one of his online presentations he had put up this slide where we can see the native aortic valve, the approximation, and the valve which is created by the pericardium. It is the Autologus pericardium which is usually used. They have a good approximate, the coaptation area is more. So this helps in in a long-term outcome, gives a good long-term result in this type of replacement. So just to go about, I will just be showing you a few videos of how we do it and what type of valves, what type of patients we are using this technique. So what we can use is either the autologous or the bovine pericardium. And one important aspect is preparation of the pericardium. It has to be stretched evenly. There is I will be just showing you the video. Then sizing of the leaflets, another important step. And preparation of the leaflets. Then suturing of the leaflets. There is a technique in which we suture the leaflets. Then fixation of the commissures. And then at the end you check the valve before you close and come off bypass. So this is a short video which I will just show you how the pericardium has to be, the maximum amount of pericardium when we are using the autologous pericardium. We have to get the maximum length and breadth of the pericardium which we can get. So one step which we have to do is use a harmonic scalpel to remove all the fat and loose areolar tissue on the pericardium. So clean it up. And harmonic scalpel, why? Because it doesn't denature the pericardium. It, at least because of its energy, you have to take little patient. You have to be patient in harvesting it, and then you cleanly cut it with the scissors. So you can see that we are just harvesting it, and take sharp scissors, and then you cut out whatever is the maximum amount of pericardium you can get. So this is the autologous pericardium which we are taking. So the next is there you have we have devised a similar type of a steel plate, a stainless steel plate with holes around it. So where the pericardium is evenly stretched, so that there are no areas where it gets crumpled, or so that the thickness of the pericardium is preserved, and then it has to be prepared in 0.6 glutaraldehyde head for almost 6 minutes. 0.6% glutaraldehyde for 6 minutes. And once the pericardium is prepared, you may be having a little bit of more tissue which you need to clean it up. So then once the pericardium is done, you go on bypass, and the first thing is that your aortotomy has to be a transverse aortotomy. You may have to almost transect the aorta in certain situations. May not be completely. It is not the regular J incision or oblique incision which we do for regular aortic valve replacement. So this is required because we have to get the commissures little more higher up than the usual commissural height. So this is just, I want to show you one of the valve anatomy. This is a tricuspid valve, and there is some calcification. It's not severely calcified. So because we are initially, we have just started this procedure, we have done only a few cases. So we have not selected like heavily calcified valves for this procedure. So we are just checking how much is the calcium, is there any calcium extending into the mitral anterior leaflet. So we can see that there are some calcium nodules in the annulus, and part of the annulus is clear. Then this is another type of patient where you should be considering this modality, this surgical modality, like where you have infective endocarditis. So we had at least 2 patients, like this person was having infective endocarditis and he had developed acute AR. You can see the vegetation and the damage to the cusp. It was a bicuspid valve with one of the cusp being large and having a incomplete raphe. So in this situation, this guy was, he was not getting febrile. We had tried to put him on antibiotics for 4 weeks. When he came to us, he developed a new MR, and we didn't have any other option because he developed a hole because of his going on infective endocarditis. He developed a hole within the anterior leaflet, and that was causing the MR. So situation was, we think of putting a mechanical valve for him. Being a young fellow, we have a high chances of he getting either a continuation of the infective endocarditis, or he could always develop a paravalvular leak and dehiscence. What we did was we prepared him for the neocuspidization procedure. Now you can see this is the first case which I showed. These are the valve leaflets which were excised. You can see the size of the leaflets. So like one of the leaflet would be usually large. This is what we have noticed in like one of them would be 23 size and another would be 25 size. Like two leaflets will be of one size and one will be a slightly larger, usually the non-coronary, even in the tricuspid. So the sizing is very important in this procedure, and you can see that this is the infective endocarditis bicuspid leaflet. You can see this hugely damaged with none of the valve morphology being leaflet morphology is preserved. So after this, after you excise and you have done all the debridement of the annulus, then you go for the sizing. Now we didn't have access to the actual sizers which Dr. Rozaki uses. So we, with some data available in some of the papers and some of the online pictures available, with one of our surgical instruments person, we developed a sizer of different sizes like 21, 23, 25. So you can see how we are sizing the individual annulus, the individual cusp. You can see. So we size it correctly 2-3 times. We need to size it so that you know that you are not undersizing it or oversizing it. Once the sizing is done, then next you go for the preparation of the leaflet. So there is a template which has also been developed by the same surgical person. So this template has different sizes, right from the 19 size, 17 size up to 31, 33 size. So what you do is you have to, using your marking pen, you mark the size of the leaflet. So what I generally do is the bites which I have to take, so which I will be coming to you later, I mark it along with the template. So these dots are marked like 3 millimeter distance, at a 3 millimeter distance. So that is the distance of the bites which we need to take on the leaflet. And then once those are marked, then you join those dots, and then you have to create a small butterfly like flap at the top end of the cusp. So this is required for fixation of the commissure, so extra tissue is needed. And just draw your line outside the dotted line, because the template is made exactly to the size of the leaflet. So if you try to make a line within the template, you may cut a smaller leaflet. So these all we learned from the initial, we had a little bit of smaller leaflets. So then later on we designed it such a way, because we need some space for the suturing of the tissue into the annulus. So this is how on the template you mark it, and then you cut it with a sharp scissors evenly without causing any zigzag lines, and you mark it on the rough surface. So there is a reason to it, so that when we are taking the suturing, I will just explain you, so that the marks will be available, will be visible to you. I am taking the cut a little 1 millimeter to 1.5 millimeters away from the line which I have marked. So after that, we got a small dish where we label each one of the cusp, the different sizes, so the left, the right, and the non-coronary, so that they don't get mixed up. And you can see that we have, in the initial stages, we used to measure with a silk the size of the cusp. Later on we developed these sizers, so it has become a little easier for us. So now this is the Autologus pericardium which I was showing. Now I would like to just show you one of the patient who was around 60-year-old and which was a small annulus. So I used a bovine pericardium. Like she had an annulus of 18. I had to think of doing a root enlargement, where I thought she was a little bit risky because of very short stature and there was a little bit of calcification on the mitral valve side. So we decided to go for a bovine pericardium. So it was the bovine pericardium we used from the Meril, which they have given for, it's not yet available commercially, but it's available for experimental purpose. So this, it was very thin and it was good to handle. Like you can see, it's quite not thick like the other pericardiums which we get from other makers. So it was quite well malleable and we could make the cusps. I would like to show you at this point a picture comparing the cusps which we had cut from the patient, and you see the cusp here. The size of the cusp is what you create. There is so much of variability in the size. So now once the cusps are made, the suturing technique. This is one of the slides I borrowed from Dr. Ozaki's presentation. Once you have let us think that this is the annular tissue which is there. So you place the cusp into the LV cavity in this position. You just put it inside the LV cavity. So this will be the rough side. And you will be having the dots here, which will be at 3 millimeter distance. So roughly the dots would be like 8 dots on each side. Like this is the center one, and here we have 4 and then another 4. So goes 3 millimeter and here 1 millimeter. Then the next bite goes 3 millimeter, 1 millimeter. So roughly like we have 4 bites coming 3 millimeter and 1 millimeter. So that is the 3:1 ratio we maintain. And as the bites are ascending up to the annulus, we take it almost at the same height. So it is like same distance. So here it becomes 3 millimeter bites and also 3 millimeter bites in the leaflet. So this is the technique we need to follow. So you can see how the most important thing is that we have to take the bites below the annulus. Initially, a few cases we were not doing like this. One or two cases we had taken the bites in the opposite direction because it becomes easier. Like for us, when you are doing the thora and suturing, you try to take it through the annulus first and then through the leaflet. So in that way, what happens is the leaflet tends to stay above the annulus. So what we could infer from this is, like you can see here in this, we are doing a suturing. So this is like the videos from one of my first few cases where I tried to suture it from first through the annulus and then through the valve. So later on we found out that this is not the correct technique. In this technique, the valve leaflet will stay either above the annulus or it will stay on the annulus. So when it stays on the annulus, there can be a little discrepancy here and there because the annulus will be calcified somewhere or it would be smoked somewhere. So you can have a little bit of irregularity in the valve way in which you suture it so that its coagulation could get affected. So then we changed our technique and then we saw that we did the usual below the subannular suturing and first going through the leaflet and then going through the annulus. Now why I said that we should be putting the markers on the rough side, like this is the rough side, so that the smooth side is open to the smooth side is open to the LV side, the LVOT. So the blood flow, when the blood flows, it is the smooth side which is facing the blood. It is not the rough side. So you have less chance of having any thrombus formations or any of the thromboembolic issues. So this is how we do the suturing. And the next important aspect is what we do is once we reach up, this portion comes here. So we fold these butterflies into the inside of the on the aortic valve. That is almost a little higher than where the commissure starts. So that is the next important step. So before you take the commissural fixation suture, what you do is you check the coaptation. whether your cooptation, just like we do aortic valve repair, like the Trussler's repair, where you see one leaflet is little lagging and you try to co-opt it and you take a pleated stitch at the commissure. So in the similar way, you want to see whether your leaflets have come in a proper co-opting, all are co-opting well. So once, if there is a little discrepancy in the length of the leaflet, you can adjust it at your co-opting, at your commissural stitch. So there you take a stitch, something like a box stitch. So the suture which comes, there will be two sutures. So one suture which you are continuing from here and continuing from here would go out of the aorta, and there will be a separate stitch which comes a little distance away. One stitch will be coming here and going out of the aorta. So you will have four stitches or four sutures coming out, which you fix them with a pledget. So the pledget will be outside the aorta, and the lower stitches will be a little nearer, and the commissural stitch which you are taking, they will be fixed, will be at a little distance. So this gives the fixation and strength to the commissure, and also you can adjust the length of the leaflet so that there is no undue leak anywhere. So once all this thing is done, so you have to get a picture something like this. So it is like, what you can see, it is not like the regular leaflets. No, they don't look like this. There will be a appearance of the fans of a windmill. It will be like a wavy, three cusps getting caught. You can see that how it is. So we are just checking for how the sutures or any other discrepancy in the suturing or anything. So the idea behind getting these first four sutures 3:1 is you get a cusp. If you take equal stitches, you may not get an umbrella type of effect. So this makes the cusp freely mobile. If you make them equal stitches, you won't get the structure like a cusp. So now you can see this is the picture which we should get. If you don't get this picture, we know that our cusp has not been formed correctly. We may have to redo it. I'll just show you one picture. Like you can see here. You can see here that we got a complete approximation and with sufficient loose tissue around. So this is how, now once you have done this, you can, there are two ways of checking the competence. Either you have to, you can just pour a little saline there, and once you pour saline there on it, you can see whether the saline is leaking into the LV. So if it is holding, then you know that your replacement or your neocuspidization is good. So you can see that saline is holding. And the other way to check is you increase the LV vent. So you try to give some suction into the LV cavity. Then you can see the approximation of the cusp. If they are good, then you know that your work has been done good. Now this I would like to show the immediate post-op TE of one of the patients. You can see how the cusps, you can see the approximation of the cusps. See the cooptation distance is quite significant, and there is no any AR. So this is another video showing another patient. We can see also, you can see how clearly you can see the cusps which are co-opting well, and this is the short axis. I would just like to show you. You can see the three cusps. Now this repair, the other thing which gives you, once you close and you come off, you can see the hemodynamics. You just check for the diastolic pressure, and you know that you have done a good work. So I would like to conclude my talk that with these points, that there is a tremendous advance on these few years as far as the valve manufacturing in our country. Especially we have seen with all the results related to Miltonia, Daffodil and MyValve, etc. The greatest advantage for our country is that we have got affordability, because this being affordable by most of our people is a great advantage, and we have to look at good functionality and durability. So my idea of presenting this technique is most of our surgeons have in practice Some of these patients may not be for everyone, but some who are in the young age, maybe 10 years old boy or a 15-year-old girl who may need this repair because of their, like he may be a sportsman and you don't want him to get into a valve replacement, mechanical valve, and you tell him you can't go for sports, you can't play. So you can always use this because Ozaki has in fact given, when we use the Autologus pericardium, he has given at least 10 years good result with almost 90%, 90 to 95% success rate. And these newer technologies, I think, is a boon to a lot of patients, like especially we have done quite a few who had been having severe infective endocarditis. And I would suggest that every surgeon should try it in the right patient. Bicuspid valve is also we can try, but at least in the initial few cases, you should not be trying in bicuspid valve because he has described a way in which you can create a tricuspid and a bicuspid, but that we have not yet tried. We are usually doing it for some selected patients. Thank you. And he has a good success rate, even up to 95%. When you are doing the correct way of treating the autologous pericardium with bovine pericardium or heterologous pericardium. Like sometimes you have a patient who has undergone a redo, like he has undergone some aortic valve procedure like aortic valvotomy, and he has a redo where you don't get autologous pericardium. You may have to use heterologous pericardium of some other patient. In those cases, the results have been suboptimal, but when you use autologous pericardium, they have been good.
Sir, what size of suture do you use for fixing the pericardium?
Yeah, the suture is 5/0. We use 5/0 suture with a taper point needle, not a taper cut.
What is the needle size?
Usually we use the same 20, the needle which we use for I think it is around 17 mm needle. In small roots and all, you can use the 10 mm or 11 mm needle which we use for the VSD closures, because sometimes it becomes difficult to, when you are taking a subannular stage, the bites become little more big if you have a bigger needle. One of the patients where the annulus was small, I had to use a 5/11 mm needle.
Thank you.
The heterologous pericardium you are procuring, is it after anti-calcification treatment?
No, there is no anti-calcification treatment here. What happens is generally in one of the patients where we had to do in a different hospital, it was the infective endocarditis child who was not getting, who was not being able to come out of the ICU because he had continuous fever spikes and all, and he was a redo case. He was operated for a tetralogy, and he had some RBOT obstruction. So we had no other option but to get a heterologous pericardium. And because at that time we kept bovine pericardium as a standby, but that particular company's bovine pericardium was very thick. So we used a heterologous pericardium from another theatre from a CABG patient. So it was something like that.